Welcome to the MPRO Stroke Through the Eyes of the ER. Your host, Mahek, will now begin.
Good afternoon, everybody, and welcome to our Disparities in Cardiac Health Program main webinar, Stroke Through the Eyes of the ER Physician. We would first like to get started with a couple of announcements. Our next DACH webinar is on June 18th, and it is titled Improving Health Care or Hypertension Care Management using your EHR and HIT. You can also follow us on Twitter, Facebook, and LinkedIn. Our last DASH newsletter will be coming out the first week of June, and the DASH team is scheduling meetings to discuss data and interventions with all practices. As always, you can contact us at dash@mpro.org with any questions or topics you would like to explore. This webinar is in collaboration with our Cardiac Land and Prevention Land. For the Cardiac Land, data reports for baseline 2014 and quarter 9 are prior to. The final quarter 10 will be due June 30th. If you have any questions, please contact Sierra Lovejoy at tlovejoy@mpro.org. Patient education kits were also mailed out last month. If you have any questions or need more tickets, please email Sierra as well. For the Prevention Land, you can access all the land podcasts through our MPRO website. They focus on preventative health topics and HIT utilization. They're available on demand through the prevention page on the MPRO website. We have another Cardiac Land webinar coming up on May 29th. That is next Thursday from 12 to 1 p.m., and that will focus on blood pressure at home. We also have a free Prevention Land roundtable webinar addressing disparities on June 25th. Now, I would like to introduce to you today's presenter, Dr. Mitchiner. Dr. Mitchiner is the Medical Director at MPRO, the federally designated healthcare quality improvement organization for the state of Michigan. His responsibilities include medical direction for Medicare quality of care reviews, clinical direction for various quality improvement activities, and supervision of EMTALA-sanctioned reviews. In addition, Dr. Mitchiner is currently an attending physician in the ER department at St. Joseph Mercy Hospital in Ann Arbor and has an academic appointment at the University of Michigan Medical School. I would like to welcome Dr. Mitchiner.
Thank you, Mahek. So what I'm going to do is I'm going to give a quick presentation here about the way we in the emergency department see patients with stroke, and then I'm going to open it up for questions. So we'll go through this relatively quickly so that there's plenty of time for questions. Can I click on it? Yeah. Okay. Okay. So we always start off with definitions. So a stroke is whenever you have an interruption to the brain's blood supply, which leads to a temporary or permanent damage or loss of brain function, or even, if it's a severe stroke, even death. Synonyms for stroke include cerebrovascular accident, abbreviated CVA, cerebrovascular insult, abbreviated CVI, transient ischemic attack, if it's very short-lived symptoms, and what you're seeing increasingly is having strokes referred to as a brain attack to sort of get people used to the idea that it's similar to a heart attack with just involving a different organ. So in terms of statistics, about 800,000 patients in the United States will have a stroke in any given year. And the interesting thing is they're more common in women because 75% of strokes occur in people over the age of 65, and women live longer than men. It's also more common in women because they have more risk factors. Because they live longer, they're more likely to have high blood pressure and atrial fibrillation. They get pregnant, which increases the risk of clots. They have higher risk of clotting disorders, probably as a result of estrogen. And they have higher risk of migraines, and if you have a migraine and you have an aura, if you have visual symptoms with your migraine, that increases your risk of stroke, particularly if you smoke. And also because obesity is higher in women. About 600,000 of these are first or new strokes. About 185,000, 1 out of 4, are in people who've had a prior stroke. It is overall the fourth leading cause of death in the United States. It's about 130,000 Americans who die each year as a direct or indirect result of having a stroke. And that means on average 1 American dies from stroke every 4 minutes of the day. The cost to the country is an estimated $36 billion each year, which includes not only the use of acute health care services, chronic health care services, but also medications to treat stroke and time off of work. And about 2/3 of stroke cases, unfortunately, will result in permanent disabilities in adults. 80% of strokes, however, are preventable by modifying your lifestyle behaviors. So primary prevention refers to things that you can do to keep you from having a stroke in the first place. Secondary prevention applies to those things that you want to do after you've already had the stroke to prevent you from having another one. So that would include taking antiplatelet agents like aspirin, controlling your blood pressure, stopping smoking, and if you have atrial fibrillation, use of oral anticoagulant therapy such as warfarin or Coumadin. Unfortunately, many patients often ignore symptoms so that by the time they are seen in the ER, it's basically too late for us to do anything for them other than admit them and put them through post-stroke therapy and secondary prevention activities. So as a result of that, there is a dramatic need for increased public education. I've always thought of stroke as a public health issue. We need to educate people on what kinds of symptoms and signs to look for, and as a result to seek medical care through the emergency department much sooner than they tend to do right now. So in terms of risk factors, your classic risk factors are hypertension or high blood pressure, elevated cholesterol, obesity, use of tobacco, use of alcohol, diabetes, patients with circulatory disease are at risk, patients who use illicit drugs, intravenous drug use, and women who take oral contraceptives. So here's a table that just shows what the prevalence of these risk factors are in Michigan compared to the country as a whole. And you'll see, for example, for blood pressure, in Michigan it tends to be a little higher than the rest of the country. The overweight, obesity is high, and diabetes is prevalent also. There are some risk factors that are basically uncontrollable. It's the things that you're born with, like your genetics. Are factors. So, and obviously your age. If you're over the age of 55, if you're a woman, as I mentioned before, certain races and ethnic groups, African Americans, Hispanic, and Asians, family history of stroke disease, a condition called fibromuscular dysplasia, where the lining of the blood vessels gets clogged up because of abnormal cell growth. That's an uncontrollable risk factor, genetic factor. And patients who have a hole in their heart between the top chambers of their heart, patent foraminal valley, also increase the risk. That's something that we typically think of when we see strokes in younger people. So you can think of about 3 major categories of stroke. There's the ischemic variety, which basically is where you have a stroke as a result of an obstructed blood vessel to the brain. There's the hemorrhagic variety, where you have a stroke as a result of a ruptured blood vessel, typically an aneurysm in the brain. And the third category is transient ischemic attack, also known commonly as mini strokes, which is due to a temporary interruption of blood flow as a result of a clot that just stays there for a little while and then breaks off and goes away. These are people that have all the symptoms of a stroke, but the symptoms are typically cleared up within 5 to 10 minutes. So looking at the largest category first, ischemic stroke accounts for more than 80% of all stroke cases. Again, this is due to obstruction within the inside of the blood vessels, typically as a result of clots that break off from other parts of the body. Cerebral thrombosis is where you have a blood clot or a thrombus that develops at the site of the clogged vessel, whereas a cerebral embolism is a situation where you have a clot typically in the heart that breaks off and travels to another body system where there is not necessarily a clogged vessel. So those two types of ischemic strokes you need to know about: cerebral thrombosis due to clots and cerebral embolism due to clots that start typically in the heart and break off. Common causes of ischemic stroke: atrial fibrillation, which is irregular heartbeat, where the chambers of the top chambers of the heart, the atria, are beating independently of the ventricles, the lower chambers. Atherosclerosis, commonly known as hardening of the arteries, generally as an indirect result of accumulation of lipid deposits within the lining of the blood vessel. Traumatic injury is an unusual cause of stroke. So, for example, somebody who has a hanging injury, or somebody's in a car accident where they hit their neck against the steering wheel. And then patients who have genetic or acquired disorders in blood clotting, where they're more likely to form clots. Hemorrhagic stroke accounts for only about 13% of all stroke cases. The situation here is where you have a blood vessel in the brain that bursts. And as a result, you have bleeding, and as a result, any of the brain tissue beyond the point where the blood vessel breaks is not getting adequate blood flow. And you also have two types of hemorrhagic stroke. You have an intracerebral hemorrhage, where you have bleeding within the tissue of the brain itself, and then you have something called a subarachnoid hemorrhage, where you have bleeding in between the brain and the tissue covering the brain. So common causes here are high blood pressure, aneurysms, as I mentioned, which is a ballooning of blood vessels where there's a weakening in the wall of the blood vessel, and it just stretches and kind of looks like a little balloon. There's arteriovenous malformations, abbreviated AVM, where you have a congenital problem here where your blood vessels are formed abnormally, and as a result, the lining of the blood vessel is very, very thin. And the other thing you have to worry about is cancer metastasis. These are tumors that start out in other parts of the body, such as the breast or the lung, and they spread to the brain. Occasionally will cause bleeding, hemorrhagic stroke. Transient ischemic attack, again, has been called a mini stroke or a warning stroke. That's where you have just a temporary reduction of the blood flow of the brain with rapid improvement. So the episodes typically last less than 5 to 10 minutes, and patients are sometimes not even aware that it's occurred. By the time they think about it, they're starting to get better, and they sort of blow it off. They get better quickly, return normal quickly. However, it's important because 1/3 of these TIA patients, these patients with mini stroke, will then go on within the next year and experience a major stroke where they have a defect in movement of their arm or their leg, or a loss of vision in their eye that doesn't go away. So, symptoms. You can think of symptoms of a stroke. Think of it using the acronym FAST, F-A-S-T. That's spelled out on the left of your screen up there. So, F stands for face drooping. A stands for arm weakness. S means speech difficulty, and T tells you it's time to get help, specifically to call emergency services, call 911. So the table there shows you the frequency of typical symptoms. So sudden numbness or weakness of the face, arm, or leg, especially on one side, accounts for about 98% of all the warning signs that you see in somebody with an acute stroke. Trouble speaking is a very, very close second. Difficulty walking, dizziness, loss of balance. Loss of vision is up there at 88%, and severe headache, particularly in somebody who usually doesn't have headaches. That can be seen in about 3 out of 4 patients with stroke. It's important to point out that if you get chest pain or discomfort, that may be a heart problem, but it's not a brain problem. It's not a stroke. And a lot of people get stroke and heart attacks and other heart conditions mixed up. So that if you have sudden chest pain or discomfort, that doesn't mean that you should blow that off either. You still need to be seen, but it usually is not a typical symptom of a stroke. You also may get confusion, blurred vision, you may have trouble walking, dizziness, loss of balance, loss of coordination, severe headache. These are some other symptoms that you occasionally see. It's important to point out that in most cases, stroke doesn't have pain like a heart attack would. And that's one of the reasons that people delay coming into the emergency department, because they're not hurting it. They think that it's just going to go away. It's also important to point out that sometimes people ignore their symptoms because they believe falsely that it represents something else, like low blood sugar or a pinched nerve or even a migraine headache. So the bottom line here is that you shouldn't take chances. If you have any of the FAST, or at least the FAS components there, it's time to go in the emergency room. Don't take any chances. Don't try to self-diagnose yourself. Just come in and be seen. We're happy to see you. And I speak for myself personally, I love it when I can give people good news and tell them that even though they were worried about their symptoms, that in fact they weren't having a stroke. So, when you do have symptoms, as I mentioned, come to the emergency department as soon as possible, immediately. If you don't think you can get there in time, call 911. Ideally, we in the emergency department like to see these patients no more than 2 to 3 hours after stroke symptoms are present. What typically happens is that you'll be sent down immediately for a CAT scan of the head to bring you a CT scan. Hopefully you'll have a report from the radiologist 15 minutes later, and by the first hour you should be talking to the patient and, if necessary, the family members about what the treatment options are if their stroke is confirmed. There's also a series of stroke centers in the state of Michigan. There's approximately 31 stroke centers now that we have. Whenever possible, it's preferred to go to one of those as opposed to your local hospital. However, we realize that time is very important here, and sometimes the best thing to do is just go to your local hospital emergency department if they think that you're having a stroke, and they can then transfer you to one of these stroke centers. One thing I do want to emphasize is that urgent care facilities, urgent care clinics, ready clinics, fast doc clinics, things like that are not equipped to handle suspected stroke cases. So if you wind up going to an urgent care, all it will do is just delay the optimal treatment that you need for your stroke. So please do not go to an urgent care facility if you think you're having a stroke. In terms of preventing stroke, lifestyle modification is very important. So obviously if you're overweight or obese, you want to try to lose weight. You want to quit smoking. If you are a cigarette smoker, you want to control your blood pressure, your cholesterol, your blood sugar. If you're a diabetic, you want to try doing all these things so that hopefully you can prevent having a stroke in the first place. Drug therapy includes antihypertensive medications, blood pressure medications, examples of which would be what we call ACE inhibitors or beta blockers. Statins, such as atorvastatin, Lipitor, are useful in the treatment of patients with high cholesterol. Anticoagulants, such as warfarin, trazine, Coumadin, is essential for patients with atrial fibrillation. And antiplatelet therapy, such as aspirin and Plavix, is essential to prevent you from forming clots. Patients should note the time and the type of symptoms for the most effective treatment. So it's important if you think you're having symptoms and you notice that your face is drooping or your arm is weak, then you obviously want to call for help, call 911, and then note the time, because the therapy that we give is highly dependent on when the symptoms started. That's another reason you want to get to the ER as soon as possible. Taking drugs like non-steroidal anti-inflammatory drugs like ibuprofen, Motrin, and other analgesics are not recommended for a couple of reasons. One, they don't help. Two, if you're having difficulty swallowing, you don't want, because of your stroke, you don't want to get the pills caught in your throat. Now, there is this drug that we give in the emergency room to patients who have a confirmed ischemic stroke. It doesn't work for hemorrhagic strokes. It can only be given for ischemic strokes. Again, those are strokes that are caused by blood clots. But you have to give it within 4.5 hours of the onset of symptoms. Not 4.5 hours after you arrive in the emergency department, 4.5 hours after the symptoms start. So that's why it's important, if you think you're having a stroke, to get to the emergency room as soon as possible. The major risk factor for this drug, TPA, is bleeding in the brain. Less than 10% of patients actually receive it within 60 minutes from arrival at the emergency department. Why is that? Because a lot of them have had stroke symptoms for more than 4.5 hours, or because they have one of many different contraindications to giving the drug. About 6%, or about 6 out of 100 stroke patients will experience bleeding in the brain with this drug. It doesn't necessarily mean that you're going to have a worse outcome, though, than if you had not gotten the TPA. And for 1 of the 6 patients with bleeding, death or long-term serious disability may occur. There's absolute versus relative contraindications to giving this drug. So, for example, if you're having a hemorrhagic stroke as a result of a ruptured blood vessel, you obviously don't want to give them a blood thinner. If they've had recent surgery of their brain or their eye, if they've had a recent injury to their hip, if they've had a previous stroke, if they have hypoglycemia, low blood sugar, if their symptoms are rapidly getting better, if they're already on anticoagulant therapy, these are all contraindications to giving this drug TPA. And if you do give it, you may not notice any response in terms of improvement. It may take several weeks before you'll notice an improvement compared to those who would not have gotten it. Surgical approaches to stroke include what's known as a catheter embolectomy. This basically involves insertion of a catheter with a balloon on the tip through a puncture of the artery to the part of the brain that is affected by the stroke. And once the surgeon or radiologist puts this catheter in there, they inflate the balloon and then they pull the catheter backwards, and as they do that, the balloon scrapes off the plaque and the clot from the inside of the artery, and you hopefully alleviate the problem. For cases where there was a aneurysm that resulted in bleeding, surgeons can go in there and repair the aneurysms, or interventional radiologists can do what's known as coiling, where they put in a really, really fine metal coil into the interior of the aneurysm that basically keeps it from rupturing. And then, of course, if you have a blockage in your carotid arteries that was responsible for the stroke, they sometimes can put in a stent to keep the blood vessel open the same way that they would do that for the heart if you were having a heart attack. Long-term post-stroke care includes rehabilitation, facilitated by physicians, nurses, neurologists, and physical, occupational, recreational, and speech therapists. Adherence to medication is very important, so it's important that you take your diabetes medications, your blood pressure medications, your antiplatelet medications like aspirin and Plavix to prevent you from having recurrent strokes. And if you are concerned about a side effect of one or more of your medications, you should not stop it all by yourself, even if it looks like you may be having a side effect that you read about internet or from the package insert. Before you do that, you should talk with the doctor who prescribed it to make sure that the doctor doesn't think it's due to something else other than a side effect from the medication. It's important in terms of recommendations to prevent controllable risk factors that lead to stroke. That means if you're smoking, you should quit smoking. If you're overweight, you should lose weight. You need to have routine periodic physicals that would include questions about family history of stroke, what your stroke risk profile is in terms of modifiable risk factors like blood pressure and diabetes and cholesterol, and whether or not you've had any symptoms that suggest you might be having TIAs. Doctors can also do non-invasive ultrasound studies of your neck to look for narrowing of the carotid arteries. You want to have healthcare professionals encouraged to discuss risk factors for stroke with patients and preparing them to look for and recognize symptoms. And you want to be able to train your frontline staff so that you can recognize symptoms of stroke or many strokes in patients who call you up to report their symptoms, to call you up from home to report symptoms. So here's a list of the 31 stroke centers here in Michigan that have been certified. Some of these are smaller hospitals that are part of larger hospital systems that incorporate stroke capability. So even if you went to one of these hospitals, you could be assured that you would be treated by people that recognize stroke and would be able to initiate early therapy and then possibly transfer you to some of the larger hospitals that they are affiliated with. So it covers a pretty wide area of Michigan, at least for the Lower Peninsula. Also, you have Marquette General and Marquette to cover the Upper Peninsula. Additional resources are listed for you here. And these are things you can download and give to your patients. And here's some additional references should you need them. So I'll end with that, and I'll be happy to take any questions.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And our first question is going to come from Stephen with
Steven Switek, the Beaumont Garfield Health and Wellness Clinic. How you doing? Nice lecture. Thank you.
Hi, Steve.
Have you had any experience where those radiologists go in and they do a opening of the head? I think in Henry Ford downtown, probably in Beaumont, they did those experimental surgeries where they go up and they actually take the blood clot out. Have you ever seen that? Is that any worthwhile?
I have not, Steve, personally seen anybody who's had that. I have referred patients to the University of Michigan. I know that they're doing it. Henry Ford, I know, has a huge neuroscience unit, and they do neurointervention studies with their interventional radiologists there. So I'm aware of it. I can't say that I have personally ever taken care of a patient myself with that. I've referred to them. And I think the jury is still out in terms of whether or not there's benefit to that.
Nice lecture. Thank you.
You're welcome.
And there are no more further questions in queue at this time.
Can you also let the audience know about the poll?
There's going to be a polling session on the WebEx section. And ladies and gentlemen, please just remain on so you can take the survey through the web.
If you would like to contact Dr. Mitchiner, you can contact him through his email address, which is JMITCHINER, which is just jmitchiner@mpro.org. He can also be reached via his telephone at 248-465-7313, and we will make this information available on the PowerPoint and when it is recorded and sent out.
One correction is actually J-Mitchin, J-M-I-T-C-H-I-N. They truncated the last two letters because it has to be 8. So it's jmitchin@mpro.org, or you can call me at 248-465-7313.
Thank you for attending our webinar. We look forward to the poll results and look forward to seeing you or having the webinar with you in June.